Hi, folks. We are going to get started in just 1 minute. While everyone gets on, we're just going to wait just a few seconds. All right. Well, thank you everyone for joining us today for our monthly RDLA webinar. We have a great panel today to talk about drug pricing. Just a reminder, we have closed captioning available. If you want to hit the live transcript button at the bottom of your window, it'll begin a transcript. And in addition, we have Spanish translations available as well. Caitlin will post a link in the chat and you can access it there. So today, as I said, we are going to be talking about drug pricing. It has been a hot topic for many years, both here in DC for Congress, as well as for many patients. And Congress is continuing to deliberate on drug pricing and what that looks like, especially with deliberations on the Build Back Better Act. So today we're joined by Sarah-Lloyd Stevenson, who is going to give us really an in-depth look at what that landscape looks like. And then Jamie Sullivan and Annie Kennedy with the EveryLife Foundation for Rare Diseases and Kelly Maynard with Little Hercules Foundation will be providing a little bit more context and information on the drug pricing principles that have come out of the Community Congress. And then lastly, Sloane Salzburg with the Council for Affordable Health Coverage. So Sarah, I'm going to go ahead and hand it off to you.
Excellent. Thank you, everyone. Can you hear me okay? Hope so. Okay, great. Sarah-Lloyd Stevenson with Faegre-Drinker Consulting. I've been honored to get the opportunity to visit with many of you and present on some of these webinars over the past 2 years. But as you likely know, we work very closely with the EveryLife Foundation on federal policy and advocacy work on a daily basis. And we do a lot talking about the FDA and research side. So I'm excited today to talk a little bit about what's happening on that third piece of access to medications, which is the very popular lightning rod, divisive, partisan topic of drug pricing. I'll go ahead and give a disclaimer that I'll provide a high-level overview of where the landscape is, what's happened in the last few years, a little bit about what's been going on, and then some of the content on actual policies, keeping in mind things change a lot in DC. And Caitlin, keep me on task here. It's 12:03. I'm going to try to not go past 12:23. So we'll see if I am able to manage that. Very briefly, and apologies for those of you, most of you likely, who already know each of these points, I did want to take a step back and talk for just a moment about the many touch points of federal law and drug policy. I already referenced a moment ago EveryLife Foundation's work related to FDA and drug approval, as well as research, all the different pieces that come into play. And I think it's helpful just to take a quick snapshot of how the federal government touches the drug development, approval, and payment kind of points along the life cycle of a drug getting from bench to bedside. Again, obviously research, I've already mentioned a lot of this, but this is again just a snapshot. If we go on to the next slide, we will look a little bit at more of the coverage pieces and how things get paid for. Very importantly, a few of the things, and this was in the previous one, but we do not need to go back, to think about when we're thinking about drug pricing is, okay, what's the actual, sorry, thanks, Caitlin. I just wanted to highlight here that we have some things about intellectual property and marketing rights, advertising, manufacturing pieces, not so much related, but in the coverage of actually what are public payers and then private payers and commercial plans actually paying or reimbursing for drugs. Those are the points when we're thinking about drug pricing, quote unquote, where federal levers can be pulled and are very often proposed to be pulled, but understandably, it can get a little trickier when you're trying to look, for example, at commercial payers, as opposed to something like Medicare, which I'll talk about in one moment. Before going to the next, I did want to note bullet 2, where we have the reference for helping incent development and perhaps recoup some costs associated with development for certain types of conditions and drugs. Obviously, we're all very familiar with Orphan Drug Act. I did just want to note, in the context of this, because we'll be talking about Build Back Better Act, the current reconciliation plan that's going through Congress, that we are tracking right now, some changes to the orphan drug tax credit that have been proposed. EveryLife has been really on the forefront of that currently. Happy to answer questions to that. It doesn't directly fit into drug pricing, quote unquote, but it is the part of that larger landscape of these federal touch points. So anyway, now we can move on to the next slide, where I will very briefly touch on, again, just a snapshot here. My big point of this is that as we're talking about these policies, keep in mind, and you all know this, but Medicare is often the biggest lever for the federal government when looking at prices, or policies rather, related to drug pricing. You'll see things related to Medicaid pop up every once in a while, but because Medicare is such a large payer, because it is the payer through which Congress has the most authority, and because where Medicare goes, as this last bullet notes, others may follow. We tend to see most of these policy proposals really be in that space and try to figure out what is the cost associated with drugs or services for Medicare. Again, I know we all know this, so apologies for the rudimentary discussion, but I did just want to flag that in case you have a question of why aren't we seeing more on the commercial front, or why aren't we seeing more on the Medicaid front? It's simply because of jurisdictional appropriateness and just size purposes. That is typically where we see federal policy go. So move on to the next slide, please. Okay, again, another probably duh moment here is, why is this such a hot topic? It was pretty easy to answer this. I probably should have just put any number of campaign ads from any member of Congress or potential elected official who's run for anything in the last decade. Pretty much guarantee that drug pricing is something that will be coming up on the campaign trail. It is always a popular talking point with elected officials and politicians who, I don't mean to sound dismissive, but like to make big promises. And I'll quote a few of them later, saying, I'm going to, impact this policy. We're going to lower the cost of drugs. As with many politics and policy issues, easier said than done. And we'll get to that in a moment as we're talking about the different policies, as well as where some parties disagree. I did want to note two quick things as we're looking at this issue and why this matters so much. Obviously, we've all been to the pharmacy counter at some point and had to pay for a prescription that ends up being a lot more than we expected, or even a lot less than we expected. And sometimes it really doesn't make any sense about why. I just want to note from the policy perspective, one of the reasons this is so popular is obviously we have the systemic issue of the cost of healthcare in our country. However, I do believe that when you're looking at prescription drug prices, that's very often a direct cost that the patient sees a little bit more directly than some other healthcare expenses. Now, that's not the case for everyone, of course, but on a whole, I think most people have had some sort of interaction with prescription drug prices and recognize, oh, this is an out-of-pocket cost I have to do right now, right here at the point of service. And for that reason, it really becomes this major political talking point and even a lightning rod. The other big caveat I wanted to note for us to think about as we're getting into the policy details a little bit more and the broader landscape is how drug policy can be very divisive and partisan. There are very few issues in Congress or on the campaign trail where you will hear a Republican and a Democrat say pretty much the same thing. I want to lower the cost of drugs. That's great. Obviously, as we all know, the devil is in the details, though, and where the rubber meets the road, it gets really complicated on how you actually meet that shared goal. And unfortunately, for the patient perspective, currently Democrats and Republicans are not on the same page on how you ensure patients have access to low-cost drugs, but also that the drug pipeline is not compromised, which we'll discuss in a moment is often the payoff or trade-off that you have when looking at drug pricing policies. Another quick thing I wanted to note, because of that partisan divide on some of the discrete policies, we do want to be mindful from the rare community, just because we are very fortunate, in my opinion, that rare policies have been, so on the FDA space and NIH space, for example, are very bipartisan. Rare disease policy is an issue that you can get. Some of our champions are from, and all of our champions are from both sides of the aisle. So we do want to keep that in mind, and this is something that we consider when engaging on these issues, because it is so partisan on drug pricing when you get down to the nitty gritty. But we don't want to confuse that issue and have to kind of look at one versus the other, especially when we recognize that something likely isn't even going to advance. I'm happy to answer more questions on that and talk about it as we get to the end, but let's move on to the next slide, please. All right, very briefly. So I said we'll do a little bit of the history of things. Again, everyone knows Mr. Trump, when he was on the campaign trail, talked a lot about drug pricing. It was likely one of the things that got him elected by the masses. This is a big topic for him. And these are just a few of the policies that he proposed during the administration. And honestly, a lot of these have been either diluted, withdrawn, or stopped by the courts. I will note the prescription drug importation piece, which is the first bullet here, is still on the books with the Biden administration, and they have actually announced some support for that in recent months, so we'll get to shortly. Let's move on to the next, and we'll talk a little bit about what Congress is doing at the same time. So, and of course, very important piece here, actually, before going to the congressional slide. Very fluid, again, just like it's very partisan, things change constantly. So this is where I often give a disclaimer of, as we're talking about policies and politics in DC, don't hold me to anything if what I say is going to happen doesn't happen, or if things get a little murky, especially as we get toward the end of the year here. Of note, you guys will notice this reference to the 50-50 Senate split with 50 Republicans, 50 Democrats, obviously Senate control because of Vice President Kamala Harris being the president of the Senate and breaking that tie. That margin has caused a lot of angst lately with the Democrat Party, which we'll talk about in just a moment with Build Back Better. But that second half of the slide here, I think is really important as we're thinking about what I was referencing earlier of what's actually plausible this Congress as we're looking at policies. So let's move on along. Okay, I feel like I'm doing okay with time, but somebody send me an emoji or something if not. So this is where things have been on either side of the political aisle over the last few years. In the previous slide, I noted that HR3, which is really the Democrats' top priority drug pricing wish list, had passed the House previously and was, of course, reintroduced with Speaker Pelosi this year, while the Republicans offered HR19. I'll just use the terms there. I think it's a little easier than getting into the titles of bills over and over again. And I do think most of us likely know HR3 by its name as such. So again, quick history of this. But one important thing that is relevant as we're thinking about the landscape for the end of 2021 is recognizing this third point here, that we had some moderates who've opposed HR3, and they continue to oppose HR3. And I say moderates, Democrat moderates. So these are members who are perhaps in a more purple district or have more concerns related to that drug development pipeline, and they've expressed those concerns to Democrat leadership. This is actually a slide I previously pulled together for a RDLA presentation this summer before we even had the reconciliation plan in front of us. And I'll just say that these members of Congress who expressed concern earlier this year about HR3 are the ones who are really upsetting the apple cart right now in the House related to passage of the Build Back Better plan, which incorporates many of the policies from HR3. I will just quickly, again, point to, and let me know if you have any questions. You can also pull up, there are a lot of great resources on this via the committee websites of how this HR19 was the Republicans' reaction to HR3. And if we go to the next slide, we will see a few of the policies that are included in each. Very briefly to go over this, because again, I'm looking more at the landscape here as opposed to individual policy pieces, but please let me know if you have questions, and always happy to follow up with you afterwards too. The core of HR3, and which will be the core and has been the core policy for the Build Back Better Act, has been Medicare drug price negotiation. This is something that has been a popular talking point and policy proposal for pretty much since Medicare was originally created Part D and started with the non-interference clause that disallowed the secretary to negotiate directly with drug manufacturers, or rather with plans for the prices of drugs. So what this does is looks at some of the most commonly used and highest priced drugs, so roughly $50 to $250, and then sets a maximum price that Medicare will pay based on the IPI, the International Price Index. So this is where some other countries are what they're paying, and it caps price, the maximum price for Medicare, based on what other countries are paying. You likely, if you're reading all the text in the previous slides, will think, okay, this makes sense from a political perspective. When one of the slides previously noted that one of the main drivers with frustration around American drug pricing is because of the rhetoric that Americans are paying a lot more than other countries. So it makes sense then from that perspective to tie the cost to other countries. And we could get into a long debate over whether or not that's appropriate, what that means for R&D in this country, given the fact that America does the most R&D for drug development. But that is really the core of this bill, as well as in kind of the stick related to the price negotiation, is that companies would have to pay back essentially an excise tax to the Treasury should they pay or charge over that negotiated price. And importantly too, that this is looking at pushing this not just for Medicare, but also for commercial payers to hold them accountable similarly. And then very popularly, again, this is the type of policy that's been proposed by both Republicans and Democrats, is just establishing this a cap, for example, for out-of-pocket limits on how much a Medicare beneficiary actually pays on an annual basis for their prescription drugs. Really where those discrepancies between Republicans and Democrats tend to be is what is that out-of-pocket limit. So then let's go to the next slide and you'll see a little bit for what the Republicans were proposing. I'll be very brief on this one in the interest of time so that we can get a little bit more into Build Back Better. These are the policies that the Republicans have proposed. This is a snapshot of it. As the previous slide noted, Republicans like to say that 40 of the policies in HR19 have actually previously been agreed upon on a bipartisan basis. These are ones that had not necessarily been, but are more of the core pieces in the bill and what would be the big changes. Obviously, you can see no Medicare negotiation. That continues to be that lightning rod issue. And if we move on to the next slide, we'll start talking about kind of next steps for things and what's happening as we near the end of the year here. I think I have a Biden administration slide next, if I'm remembering correctly. Yep. Okay, I said I would quote at least one politician from the campaign trail, but President Biden, when running for office, said he would lower prescription drugs by 60%. Laudable, I think we all support that goal. I think that is a good goal. It is a difficult one. Again, everyone agrees prescription drugs should be lower. It is just how do you do it from a policy perspective at the federal level. They've done a lot in the last year to try to get at this issue. I just want to note two major things here in the last couple of months. First off, there's an executive order in July. I said earlier, I would mention again, drug importation. This is where the administration had previously been a little I shouldn't say wishy-washy, but they hadn't gone out very publicly on drug importation. And in this executive order, which was actually much broader than drug pricing, the president directs FDA to work with states to allow drug importation programs, which is the exact policy that the Trump administration currently has on the books as finalized December 2019. 2020, I think. And then it looks for a lot of legislative reform. Very importantly, calls out Medicare negotiation. And I want to note that, and again, I won't read this whole slide to you, but you can see it, getting the FTC, for example, to look at monopolies and issues that are unfair and uncompetitive. But then if we look to one of the follow-ups from this was for HHS to issue a report on drug policy. So in September, we have this report from HHS, which I will flag again. It talks about the need for legislative action and specifically on Medicare drug negotiations. So you keep hearing me say that because it continues to be a pillar of drug policy debate on the Democrat side. Let's go on to my next to last slide here. So hopefully you all saw this coming as I referenced it throughout our conversation today, that the Build Back Better Act, also known as the Reconciliation Plan, the budget bill, whatever you may want to call it, that has been going through Congress for the better part of the last several months, has as a core policy actually looking to enact these priorities that we've talked about in the last few slides from the Democrat side on drug pricing. So I'll talk very briefly about what that includes. So for the most part, it looks a lot like HR3, not surprisingly. This requires HHS to annually negotiate with drug manufacturers for the highest price and most commonly used, again, you heard me use that term before, prescription drugs. This includes insulin, which, again, when you think of lightning rod issues and talking points, insulin is often raised given the discrepancy in prices related to insulin. It requires a drug manufacturer to increase their prices faster than inflation, so what we talked about previously, to pay back that excess amount. And this is attempting to, and I'm reading a quick quote here just from Democrats' Energy and Commerce Committee, helping to hold down the rapid increase in drug prices for consumers, both in Medicare and as employer-sponsored plans. And then caps out-of-pocket prices for that $2,000 a year, calendar year price for Medicare. And I don't think I noted earlier, but that's for Part D. So, and also I should note as well, since we had on the Trump slide, some of the policies that the Trump administration proposed is blocks implementation of the regulation that would increase premiums potentially for Part D beneficiaries. Very importantly, when HR3 was originally scored, and we've seen similar scores, again, that's the Congressional Budget Office, saying how much a particular piece of legislation or policy would cost the federal government. They said that this could reduce costs of the federal government by roughly $450 billion over 10 years. 10 years is the budget window that they typically look at, but also would, again, on this R&D and like what does this do to the drug pipeline, they noted that it would anticipate 8 to 15 fewer treatments would be brought to the U.S. market over the same time frame. When you look at the whole U.S. drug supply and pipeline, that may not seem too significant, but that is enough of a concern for Republicans and some others to oppose this. Obviously, some folks in the pharmaceutical industry who are estimated to lose roughly $500 billion to $1 trillion in revenue over the same time period based on this policy. It's tricky. CBO does note, and I appreciate this from their perspective, that you can't really, it's kind of proving a negative. It's difficult to say what wouldn't happen if something does happen. So they note that it's difficult to say the exact impact of the policies related to the market and approval of new drugs. So again, a lot of this is stuff I've been kind of hinting at throughout our conversation, but the two big challenges, number one, I previously noted those members of Congress who had, first off, opposed HR3 policies during the earlier time in this congressional work period, deliberation of HR3, as well as wrote to Speaker Pelosi saying we still don't like these policies. They, once again, some of them opposed the policies as it was going through the congressional hearing process last month, in September. So we're continuing just to hear from those members, Schrader, Peters, Rice being three of the important ones. They actually just introduced a new bill called the Reduced Costs and Continued Cures Act, which would essentially water down these policies we've discussed here that are currently included in Build Back Better, and would focus them primarily on Part B, looking at not touching negotiation for Part D drugs. So the other very obvious snag is the Senate snag, about which you have likely all heard in the news. If you had seen any copy of Politico in the last couple of months, you know that Senators Sinema and Manchin, two Democrats who are a little more middle of the road, have a lot of concerns with the larger Build Back Better Act, and thus are really holding up the process. And I will quickly try to wrap up on this, and happy to take any questions now that we may have, especially on this, since I'm not talking too much about it. The big question right now is what happens to this? I mentioned Build Back Better, also known as reconciliation, is going through the reconciliation process in the Senate, which is a budgetary mechanism through which Democrats or Republicans have done it too, can pass bills on that simple majority 50 vote threshold, or 51 when bringing in the vice president as a tiebreaker, as opposed to having to deal with the filibuster. Because of that, though, because it's a budget mechanism, they have a lot of restrictions on the types of policies that can actually be included in the package, but they've managed to include these drug pricing pieces as a real core focus. And it is actually drug pricing that is one of the biggest concerns of Ms. Sinema, who is currently blocking with Senator Manchin the actual advancement of the bill. Again, you likely have all seen, there have been a lot of different things put on the negotiating table. Importantly, I would note Sinema and Manchin are actually a little bit at odds on the changes they actually want to the larger package. Sinema is a lot more opposed to the drug pricing piece than we hear Manchin talk about. So when you think, or if you hear a headline that says, well, reconciliation may move forward, and the White House is meeting with people. It's important to note that just even if they get Manchin on board, that doesn't necessarily mean that Kristen Sinema will similarly support the package. So that is the current state of play. Anyone in Washington who tells you they know it's going to happen, don't give them too much credit. I spoke to staff on Senate Finance Committee yesterday who said it is possible this debate continues to go into 2022 because so little headway has been made in recent weeks. And they do currently have on the Democrat side an arbitrary deadline of October 31st to wrap up negotiations, which has not yet happened. With that, I did go a couple minutes over my expected time, but thank you. Apologies for throwing so much information at you in such a short period of time, but happy to hear any questions related to the landscape. Any of the more detailed policy ones I may want to hold off for later.
Wonderful. Thank you so much, Sarah-Lloyd. I don't see any questions for you in the chat. You must have just explained it so extensively that there was nothing left to ask. But if folks do have questions, Sarah-Lloyd is going to stick on for a little while longer, and you can just put your questions in the chat and Q&A. So we'll go ahead and move on to our next round of speakers. We actually have Jamie Sullivan with the EveryLife Foundation, Anna Kennedy with the EveryLife Foundation, and Kelly Maynard with Little Hercules Foundation to talk about the rare disease community and drug pricing policies. And I believe Annie's going to kick it off.
I think Jamie's actually going to start us off. I do want to just, maybe you could pin all of us or open it up so they can see all of us, because I think we're going to tag team this. I do want to just, first of all, thank Sarah-Lloyd before we hand it over to Jamie, and just say for everybody, this is a lot. In listening to Sarah-Lloyd, I just learned a lot, so thank you for that recap, Sarah-Lloyd. And it is like sipping out of a fire hose when you think about all of this policy and everything that's happening. And the whole purpose of doing this is just to provide everybody with an overview of the landscape, which is ever changing. As Sarah-Lloyd mentioned, things changed even this morning and late yesterday in some of this landscape. So it is not our expectation that anyone feels like experts, although maybe some of us here are. We just want to provide everyone with the tools to feel like you even know how to track it and engage as you want to and need to, or to be talking to your patient communities about this or answering questions. What we're going to move into now, and Jamie's going to kick us off, is to talk a little bit about how our community Congress felt it was important to be engaging, because most of the policies, actually all of the policies that Sarah-Lloyd just started to navigate, were really developed without the voice of the patient community integrated into them. And what we felt was really critical was that as these policies were being considered and moved forward, there were really core principles through the lens of the patient community that needed to be considered and thought of. So we're going to walk you through what our community Congress partners developed as drug pricing policies that needed to be integrated into any policies or legislation that move forward. So Jamie.
Great, thanks Annie. So yeah, Sarah-Lloyd's given a wonderful overview of all that's happening in the world of drug pricing policy. And like Annie said, it's a lot. And it's sometimes hard to sift through all of that noise and get to the bottom line of the impact that any of the various policy proposals may have on you now and in the future as rare disease patients and advocates. So the EveryLife Foundation has worked with our community Congress partners in 2019 first, and again earlier this year, to think through what are the most important goals to come from any drug pricing policy proposal, specifically as it relates to the needs of the rare disease community. We know that the pain people feel when they can't afford a prescription is real, but there's an added layer of consideration we need to think about as a rare disease community, and that's the fact that 95% of rare diseases have no treatment at all. And we need to factor in the impacts on the environment for developing those treatments. It's just not the same as as it may be for some of the blockbuster treatments that often are the ones that you see come under the most scrutiny in high-profile hearings and new media coverage. And it's important that we understand, that there may not be a one-size-fits-all problem and a one-size-fits-all solution. So we're going to walk you through where we landed as a community on these goals for drug pricing proposals. And you can find the full statement on our website. You see the link there. Maybe we could put it in chat, but it's under policy issues and under access, and you'll see the full drug pricing statement that contains some additional content. So go to the next slide, please. So we broke the principles down into 5 different sections. So I'm going to cover the first 2 and hand it off to Annie and then Kelly. And I think, most important to any conversation is that we support policies that will continue and improve on efforts to incentivize rare disease therapeutic development. We know that there's been tremendous progress since the Orphan Drug Act was passed. That's, the most consequential rare disease incentive that there has been, but so many have not yet benefited, and we have to do more and ensure that harm is not done at the same time. So the first principle in this section, essentially that policymakers must recognize the differences and the unique complexities of developing therapies for areas of high unmet need like rare and ultra rare diseases. So we need to ensure that we're educating members of Congress on what those complexities are, so that they understand that it's not a one-size-fits-all solution. It is not a one-size-fits-all problem, most importantly, that solutions that are designed for medicines used in high volume may have devastating impacts on those that might be ultra rare. And we need to explain the why behind that, give real examples and real stories. And as you evaluate drug pricing proposals, keep this in mind. Are they treating it as a one-size-fits-all solution? So secondly, on this list, we should ensure that existing incentives are not removed in any drug pricing plans. And this goes back to an example Sarah-Lloyd mentioned for right now happening. It's not directly tied necessarily. We may not be associating it with the drug pricing conversation, but one proposal in the House Ways and Means version of the Build Back Better reconciliation bill would remove one incentive by changing the orphan drug tax credit to be only eligible for the first approval. So the tax credit, which was already cut a few years back as part of the tax reform bill, it enables companies to get a credit for about 25% of the cost for clinical testing of rare disease therapies. And the proposed change would make that tax credit only applicable to the very first approval, which would mean the companies lose a major incentive to go back and do the additional clinical trials that would be necessary to see if a treatment works in another rare disease. And so we've been collecting examples from the community where this investment has, really meant meaningful improvements in therapeutic options that are available to patients that otherwise may have had none, and where there's areas of that promise in the future. And so we can really use those stories to educate members of Congress why it's important to preserve this incentive. So similarly, in the third bullet, we want to not just protect what's there, but continue to consider new ways to incentivize the development and repurposing of treatments for cures for rare diseases. So, as the science evolves and as, things like individualized therapies evolve, cell and gene therapy, our policy innovations should too. And so we need to think creatively. We need to, have the resources and the policy flexibility that will really keep up with our innovations in science. And next, we want to call out the importance of expedited pathways in rare diseases. So an example here would be the ongoing discussions of policies that would treat reimbursement for drugs approved via the accelerated approval pathway differently than others. The expedited pathways are essential in rare disease. And we just yesterday convened a full-day workshop about how to optimize the accelerated approval pathway for rare diseases, and policies like those proposed recently by MACPAC that would implement a different reimbursement for accelerated approval therapies for a certain time would do not reflect the reality of the needs in rare disease. And we should not be doing things that might disincentivize the use of that pathway in the future. And lastly on this, it's important to stress that we want to maintain the integrity of the programs in place for incentivizing rare disease therapeutic development. If there are bad actors and those trying to abuse those incentives, we should be looking to ensure that policies prevent those loopholes, but we have to do so in a targeted way, that focuses specifically on the problem and not making broad changes that would have unintended consequences beyond what they're trying to solve. So we can go to the next slide. sorry, we're going through this again pretty fast to get through in an hour. So the next category, I'll be quick because I think it bleeds into a little bit of what is in the next group, but we want to be clear that we believe the FDA's role is to ensure therapy is safe and effective. That's their mandate in our laws. It's what, you know, the rare disease community wants, safe and effective therapies. And that is the FDA's job. But in some policy conversations now and in the practice of some payers, there's suggestions of, you know, additional layers of review. We see payers making determinations if a product is worthy of reaching patients. And that's the FDA's role, that determining a product is safe and effective for their intended use. And so if the FDA has made their determination, policies should support the timely access to those products. So I'll stop here because it starts to bleed into some of the things that Annie's going to talk about around value and innovative payment models.
Thanks, Jamie. So this next category, actually, I'm just going to not read through the bullets, but give you some examples because we've talked about a couple of them. So this one speaks to innovations and payment models. And I think one of the things that I really appreciate about the principles that we work together as a coalition to develop is that they really lend themselves to a number of the different policies that we've seen come up. So this first one, which really talks about that we really need to be looking at how we generate evidence to support disruptive innovation in the models that are being brought forward. We really can look at this either when we're looking at forward-leaning proposals or when we're looking at needing to push back on proposals that are coming forward and look for whether or not there is evidence to support these proposals and whether or not they could be harmful and rare. So just some examples is there have been models that have been brought forward that could be harmful in rare disease. We've been able to really look at whether or not there's data to support them and how that data could be used to help dissuade those proposals from moving forward. So for example, Sarah-Lloyd was just talking about IPI or the International Pricing Index, and someone actually dropped into the chat a really great point that in many countries outside the US, there's either delayed access or no access to therapies that have been approved in those countries due to the price controls in those countries and some of the methodologies to assess access. We need to ensure that we don't block access here in the US. And there was actually a study that was conducted by, so to the point of evidence, CSLA or the California Life Sciences Association found that IPI could result in an 88% reduction in the number of drugs that were brought to market by small and emerging companies just in California. So that's just an example of how some of these principles can be used to help either support or dissuade policies that are moving forward. For this next bullet, alternative payment models are a really important way for us to think about how we move products forward and enable access. And I'm not going to spend a lot of time on this because Sloane's actually going to talk about some of the policies that are moving forward right now. So we'll spend some time of this in Sloane's presentation. And then this last one really talks about, there have been a lot of ideas brought forward on how we address therapeutic prices. And some of these are being done in the form of demos or policy experiments, but they could be really harmful to our rare disease community. And we need to ensure that rare diseases are excluded from these policy experiments. And so an example is there's right now proposals by MacPac and ICER on these new reimbursement policies that would increase rebates on drugs that receive accelerated approval until post-market clinical trials confirm that the drugs work. So again, there are some harmful proposals out there that we're working to ensure exclude rare disease or not apply to rare diseases because they'll block access to our therapies. There are many more examples like that, but for the sake of time, let's keep going. For this next one, Qual, I just want to spend a second on Qual. Keep going. Next slide. To talk about what Qual is for people who may not know. You probably hear a lot about the term Qual. The Qual is a methodology that's used to evaluate value of a product or an intervention. And I think it's important to say that we do care and think that value should be assessed. We need to inform our decision-making when we're thinking about which therapies at which time and which combinations. And there's a lot of great work out there being done to assess value and to ensure that values that matter to patients are put into the center of those methodologies and those frameworks. And so we're working very closely with many of those partners to ensure that we continue to do that work and expand on that work. But one of the methodologies that are most flawed, and the National Council of Disability published a study in 2019 to really point out the flaws in the QALY, is this quality adjusted life year. And the reason being that it presumes that to get to ultimate quality of life, you have to have optimal health. And individuals who have a diagnosis of a rare disease or a chronic disease or a disability will never achieve optimal quality of life using this methodology, which means that no treatment that we produce or approve will ever achieve full quality unless it cures the individual or removes the disability. So it is a flawed discriminatory measure when we think of disability and rare disease. And there's a lot more data on that, but I think it's important for you to know that we as a community really push back on use of the QALY and any policies or proposals. And there are other methodologies that are being proposed and developed in policies. I think we can go to the next one, and Kelly's going to talk about the next section. All right, Kelly.
Thank you, Annie. So I'm going to spend a few minutes talking about the current state of play for patients, rare disease patients, when they're trying to access newly approved therapies, and how that leads to increased costs. Because, as many of you know, many rare disease patients are suffering from progressive, life-limiting diseases, and by the time they're actually getting access to these newly approved treatments, they're much sicker, which obviously drives up healthcare costs for them and their families and the system in general. So, number one, ensure policy solutions better align patient access to time of approval rather than imposing further process delays, especially for diseases that are irreversibly and progressively debilitating. What this means is that when a drug is approved, it does not mean access per the label for these patients. Most of the time, they're having to go through a prior authorization process, which many times limits access to very few patients and not all eligible patients. And so they can, no payer that I'm aware of is covering these at approval. What we see is they are taking the time to sort of re-review the science of the particular treatment and then issuing a policy of coverage. And that can take many, many months after approval. Seek policy solutions to decrease burdensome utilization management barriers, which lead to delays in patients accessing therapies. What this means, what we see is the utilization management and review process is the same for the, a rare disease patient with a terminal condition or very, very serious condition, is the same for as a patient that is trying to access a newly approved acne medication. Many of those are not going to be on their formulary. So they're going to have to go through the utilization management process. And that can take up to, we've seen it take up to 9 months to a year in extreme cases. Coverage and reimbursement policies should ensure patients have access to appropriate FDA-approved therapies in consult with expert healthcare providers. Many times, that this happens in the drug development process and the approval process. But this expert consultation with disease experts that actually treat the conditions in clinical settings are not consulted when they're developing these policies of coverage. I would even go so far as to add that patients should weigh in on that as well. Seek policies that create transparency in the healthcare system or in how pricing decisions and access to determinations are made. It's very difficult for patients and advocacy even to talk about healthcare pricing and how drugs are priced, because that whole process is just behind a big black curtain for us. We are not made aware of how that happens. And so I think that one is pretty self-explanatory. And policy solutions should seek to lower overall out-of-pocket costs for patients and families and spread cost over the annual plan term. I mean, you know, there's always this focus on drug cost, but, you know, I don't have to tell you all that it's the total cost of care that really is, you know, over a whole disease experience is, you know, equipment is ridiculously expensive, and you have to go through the same delays and processes that you have to do to access drugs. So, you know, really need to look at that as well when we're talking about caregiving, providing care, and the cost of care for many of these rare diseases. Oh, and I did have, sorry, I had to check my notes. Another example of this, that last bullet, is copay accumulators, something that's getting a lot of attention right now, that shifts the cost of many of these expensive treatments back onto the patient to the tune of tens of thousands of dollars. And there is a lot of work being done to ban those, but just wanted to highlight that as an example.
Thanks, Kelly. And I'll add in one thing here too. Many of you might have heard of some of the policy proposals as it relates to this last one around capping certain costs like Medicare Part D, annual costs that you're responsible for. And then with the second piece of this, spreading costs over the annual plan term, we know that there's been a rise in the popularity of high deductible plans. Maybe not in the popularity from the consumer, but from the payer offering them. There have been, you know, increase. And so, you know, it's not very logical why someone might be able to afford a $5,000 charge in January, but then, you know, meet their deductible and have, you know, much lower costs the rest of the year. We know household budgets don't work like that. So policies should be focused on spreading those costs over the annual term to really reflect the reality of the average family or individual's, you know, financial situation. It's not remarkably different in January than it is the rest of the year. So these are some common sense, I think, across patient advocacy that are not just rare disease specific, but very much common sense, you know, patient consumer friendly proposals. But we're happy, I think that's the end of our segment. We're happy to answer questions or let Sloane, you know, take over with her examples and ask from there. Caitlin, whatever you prefer.
Great. Yeah, I don't see, we don't have many questions in the chat. So I think with the limited time, we'll go ahead and move on to Sloane to talk about the different drug pricing update. So Sloane, I'm going to hand it off to you.
Thanks, Shannon. I think you can go ahead 2 slides. Just a quick, I know I've presented to you guys past, but just a quick who I am. So Sloane Salzburg with the Council for Affordable Health Coverage. We are a DC-based coalition aimed at improving affordability and access to healthcare across the spectrum. And I always pitch as we're the conveners. So we've got patient groups, we've got pharmaceutical manufacturers, payers and PBMs, employers, and some tech companies. And so what we really work at trying to find is those policies that would bring folks together, and then we go up to the Hill and advocate for those. And in the drug pricing space, which as all of the previous speakers have done a fabulous job kind of covering this very, very complicated issue, I'm sure you guys can guess, we've got the payers and the insurers and the PBMs on one side, and then the manufacturers and on the other side, and then patient groups are like, hey, I just need to get my drug. And everybody's pointing fingers and blaming folks. And so what we really try to do is figure out policies that bring the folks together and that actually improve access and improve affordability of these, rather than there's a lot of stuff being you know, and I think Sarah-Lloyd covered those. There's a lot of policies right now going on Capitol Hill that don't necessarily trickle down and affect patient access. They affect the government pocketbook, essentially, because they can save the government money by taking flesh out of pharmaceutical companies. So one of the big issues that we've been focusing on through CHC is value-based payment arrangements. And I know I've done a few presentations to these groups. I'm going to review what these are in the next slide, but we have a dedicated campaign called the Campaign for Transformative Therapies, which is just geared towards, specifically targeted at developing and advocating for policies that enable these value-based or outcomes-based arrangements for rare disease gene therapies. So if you go to the next slide. So this is just a really quick overview. I know Sarah-Lloyd kind of went over the complicated, the multiple packages that are going through the House, through the Senate, what the president is talking about. But I wanted to do a quick little screenshot of the calendar for the rest of the year and into early next year. And so, December 3rd is kind of the new big number or date that we're looking at for congressional action, although there is an October 31st. I put quotes around this deadline because I don't think that I believe that it's real. But December 3rd, if you guys remember back at the end of September, there was this big debate around the debt and the United States reaching the debt limit, and we were going to default, and then we weren't going to be able to fund anything. And Congress really quickly stepped in and basically punted down the line to December 3rd. So December 3rd is our new kind of like date that the government funding ends. We have a continuing resolution that runs up on December 3rd. There are a couple of other, we call them must-pass legislation. It's not necessarily healthcare. There's TANF, there's COBRA subsidies. There's a bunch of stuff that all run out on December 3rd. And so what this means is this is kind of the new deadline that Congress has to act. And so when we're talking about reconciliation, we're talking about any other must-pass policies, it's going to happen around December 3rd. And then December 31st, there's a whole bunch of other kind of deadlines that they're going to hit. And so, this is like a complicated list. I'm happy to answer any more questions, but I know we have limited time here. But just all this means is that December is going to be a crazy month. We're probably going to have what we call them Christmas tree bus bills. So it's going to be one giant bill that's going to have a whole bunch of stuff in it. And what I know the EveryLife Foundation is doing, I know what we're doing at CHC is trying to pick through the noise and figure out what healthcare policies are going to be tacked into this, specifically the drug pricing space, what's going to happen. And so Sarah-Lloyd did a great job kind of covering the various scenarios. I also have no idea what's going to end up happening, but I do know that we're actively lobbying against the bad ideas. So those HR3 things that we think are going to impact innovation in this space. And then really advocating for, Congress right now is looking to do something. There's both Democrats and Republicans, they don't want to go back home and they don't want to say we weren't able to do anything. So my goal when I have Hill meetings, and I really suggest you all, if you have Hill meetings, is you don't say don't do something, you say don't do this instead. And so one of the do this instead areas are value-based payment arrangements. So if you go to the next slide. So really, really quickly, value-based payment arrangements are when you base a payment on an outcome, or they're sometimes called outcomes-based contracts. And so if a drug works, you pay for it, and if it doesn't work, you don't pay for it. That's kind of at their base. These are pretty complicated, as I'm sure you can guess, and I know I've gone through this before, so I'm not going to go super detailed. Happy to follow up with anybody if you have more detailed questions. But Kelly actually made a really good point earlier on talking about the time to therapy. One of the interesting kind of potential positive impacts that value-based payment arrangements have is that it would reduce the time to therapy, because if you have a value-based payment arrangement in place, so if a state Medicaid program has one of these in place with the manufacturer for a brand new drug, that means that they're not doing all those utilization management stuff on the front end. They're actually doing it after you get the drug, because payment, the outcomes, it's all based on once you get treatment, how that treatment's working. So that's kind of an interesting thing to also think about with these. Now, in terms of legislation, because I know I only have 5 minutes and I'm going to try to do this in like 2 minutes. Senators Crapo and Burr introduced Senate Bill 2164. This is the Senate version of that HR19 that Sarah-Lloyd was going over. And it's the quote unquote Republican alternative to kind of the HR3. And it has a bunch of stuff in there. But one of the pieces that we really like in this is actually really good legislation on enabling these value-based payment arrangements so that you can get them in Medicare and Medicaid in the private sector. And I kind of outlined high level what's in that piece of legislation. It's sections 121 through 123. And it fixes some of the price reporting issues that value-based payments have so that you can allow for deep discounts. So you can allow for a 100% refund if the drug doesn't work. It fixes some of the fraud and abuse issues. Again, the anti-kickback statute. Manufacturers are not allowed to give anything of value away to federal health programs because it's seen as a kickback. Essentially, if they were reduced the price, that could be considered a kickback. And so it protects these from that. It ensures state Medicaid programs get the same deals. So, you don't just have the private sector that's getting the really good deals. It defines them broad enough that it's not just, based on one type of clinical outcome or one type of adherence outcome. It's pretty broad, but still has kind of the guardrails in there. And so it bases price of a rare disease, and they call it a transformative therapy on predefined outcomes or measures. And it also has a GAO study in there to make sure that because these are still relatively new, that they improve access so patients are able to get these, that it lowers, Kelly talked about this, lowers overall system costs, and you're lowering patient costs, because what these are really doing is they're showing the payers actually see value because these are, potentially curative. They're very durable treatments. And so they don't want a barrier for patients to get these. And so one of those barriers is obviously out-of-pocket costs. So a lot of these value-based payment arrangements are lowering those out-of-pocket costs. So what we're trying to do is, and I encourage you all, I'm actively on the Hill asking particularly right now, Democrats to support this provision, these sections 121, 123 of this bill in reconciliation as one of the good ideas for drug pricing. And so that's kind of really what I'm here to talk to you guys about. If you have any questions, feel free to ask me, and I will end with 3 minutes to go.
Thank you, Sloane. And your email address is here for any questions that folks want to get in contact with you about. I did see one question in the chat for you around how this bill would fix the Medicaid best price issue if a 100% refund is issued if a patient doesn't respond to treatment. In the chat. If you don't have an answer right now, we can just ask that person to get in touch with you afterwards.
I can give a quick answer, and Kelly, I can follow up with you too. It exempts, so there's a list of exemptions from Medicaid best price. Actually, Medicare Part D is one of those. Any drug in Medicare Part D, you can give bigger discounts. That's why Part D has a lot of discounts. So it adds value-based payment arrangements to that exemption list, which means that if you have a discount that's larger than the statutory 23.1, that it exempts value-based payment arrangements from best price so that you could give a lower price and you don't have to basically provide it at $0. So if you give that price concession of 100%, you wouldn't have to then provide it at $0 for the entire Medicaid program. What it does is you would have to provide those same terms for a value-based payment arrangements to the Medicaid program, but you don't have to do that blanket kind of $0 essentially.
Great. Thank you so much. I do want to thank all of our speakers today for joining us today. I know it was a lot of information, and I really appreciate all the preparation that went into sharing it with all of you today. And since it was a lot of information, as always, our webinars are recorded. So they will be posted on our website most likely later today. This will go up on our website. You can always find the recordings at rareadvocates.org/webinars. Also, our speakers are always open to you contacting them with questions later on. If you need help getting in contact with them, please don't hesitate to reach out to myself or Caitlin. As Annie said, we hope that this was really informative to you all as you engage and advocate, and these discussions on drug pricing continue. And our next webinar will be on November 18th next month at noon Eastern time. If you'd like to speak or have any topics that you'd like to be presented during that meeting, please don't hesitate to reach out to Caitlin. And I just want to end with thanking you all for coming today, and thank you to our supporters who make these webinars possible. So thank you all for joining us, and have a great day.